Imagine just one single medical advancement, something that has fundamentally reshaped, well, all of human history, preventing millions, maybe hundreds of millions of deaths, altering the very landscape of infectious diseases.
That's exactly what we're diving into today, the incredible story, the revolution of vaccines.
Welcome to the deep dive. Today, we are taking on a massive topic, honestly. It's the incredible journey of vaccine development. We're going from its empirical, almost accidental beginning.
Right, like Jenner and the milkmaid.
Exactly, all the way to the cutting-edge mRNA technologies that are, well, they're changing global health right now as we speak.
And we've really sifted through a lot of information for you. We're looking at the core science, the historical turning points, and then we're doing 5 specific deep dives.
Yeah, into some critical ones. Influenza, respiratory syncytial virus, RSV, SARS-CoV-2, of course, varicella, that's chickenpox, and measles.
Our mission for you, the listener, is really to pull out the most important nuggets of knowledge, give you some surprising facts, maybe things you didn't know, and help you really grasp what matters in this complex but absolutely life-saving field.
Think of this as your shortcut, your essential guide to being genuinely well-informed on one of humanity's greatest achievements. Period.
Get ready for some aha moments, I think, some fascinating history, and definitely a look at where preventive medicine is headed next.
Okay, let's unpack this incredible story. Okay, so we all kind of know vaccines help us fight disease. But let's really get into how. How do these tiny vials of liquid, often just a quick jab, prepare our bodies for this fight against invisible invaders? It starts with a pretty clever trick, right?
It really does, and it's a profound principle when you think about it. The core idea, the genius behind vaccines, is that they safely imitate an infection without causing the full-blown disease, crucially, and avoiding its complications. This imitation, this safe mimicry, is foundational to immunization. That whole process where you become resistant to an infectious disease, building a shield before the real threat shows up.
So how does that imitation actually work inside us? What's the active part?
Right, the active ingredient, no matter the type of vaccine, is always an antigen.
Antigen.
Think of an antigen as a unique flag, like an identification marker on a pathogen. It's any substance that triggers your immune system to produce antibodies.
Antibodies. Got it. Proteins, right?
Exactly. Specialized proteins made by your white blood cells. And their job is to identify and neutralize these foreign invaders. They tag them for destruction, essentially. And here's the critical part. After your body successfully clears that infection, whether it was a real one or just this vaccine-induced imitation, a small number of these specialized white blood cells, these memory cells, they stick around, along with some antibodies.
Memory cells, so the body remembers.
Precisely. They provide long-term protection. That state is called active immunity. That's the real aha moment. Your body remembers how to fight back quickly and effectively if it sees that same invader again.
Okay, so active immunity is when my body builds the defense. But you hear other terms thrown around like natural immunity or maternal antibodies. How do those fit into this whole protection picture?
Yeah, that's a good point. It's important to see the different ways we can get protected. If we step back, immunity falls into broad categories. Active immunity, like we just talked about, is when your own immune system learns and responds.
Right.
That can happen naturally, by actually getting sick, having the infection, symptoms or not. Or it can be vaccine-induced through that safe exposure we discussed, kill pathogens, weakened ones, or even just key parts of them.
So natural infection or vaccination both lead to active immunity.
Yes, and both take a little time to develop, maybe a few weeks. But they generally offer robust, longer-lasting protection because your own immune system did the work. It built the memory.
Okay, so what's the alternative? What's passive immunity then?
Right, passive immunity is entirely different. This isn't about your body making its own antibodies. Instead, you're given antibodies from somewhere else, another human or sometimes an animal.
Given them. How?
Well, the classic example, and it's really quite amazing, is maternal antibodies. They're transferred from the mother to the fetus across the placenta during pregnancy, or through breast milk after birth.
Ah, okay, so the baby gets temporary protection.
Exactly. Crucial protection when their own immune system is still developing. Another way is through antibody-containing blood products like antitoxins, given in a hospital maybe, for immediate defense against something like tetanus toxin.
So it works right away.
It provides immediate protection, which can be absolutely life-saving in certain situations. But, and this is key, it's temporary. Those borrowed antibodies degrade over time, and your body isn't making more of them. So the protection usually fades within weeks or months. It's like a borrowed shield, not one you forged yourself.
Okay, that makes sense. Now, vaccine science itself, it's not static, is it? It feels like it's constantly evolving. Especially recently, we've gone from using like the whole bug
Right. All
to
the
just
cell.
tiny pieces and now even genetic instructions. These different platforms, as you call them,
Right.
why are there so many and why does it matter which one is used?
That's a really central question. Because this evolution in vaccinology has given us this incredible toolbox, a diverse range of approaches. And each platform, each type of vaccine, has its own set of advantages and sometimes limitations.
Okay.
The choice of technology directly impacts, well, everything. Its safety profile, how well it actually stimulates that immune response. We call that
There's
immunogenicity.
immunogenicity.
How many doses you might need, how quickly it can be made, and all of that dictates who it's suitable for different age groups, people with weak immune systems, and the kinds of public health strategies you can realistically roll out across the globe.
So to really get this revolution, we need to understand the different tools. What's the oldest, most traditional approach?
Historically, and maybe conceptually, the simplest are the live attenuated vaccines.
Live, but weakened.
Exactly. They contain living forms of the pathogen, bacteria, or viruses, but they've been weakened or attenuated in the lab so they don't cause serious disease in people with healthy immune systems.
So they still grow a bit inside you.
Yes, and that's the key. They replicate just enough to mimic a natural infection really well. This stimulates a very strong, often lifelong immune response. Think of the MMR vaccine, measles, mumps, rubella, or the chickenpox vaccine, varicella. Often you get great protection with just 1 or 2 doses.
But live sounds like there might be a catch.
There can be. Because they contain a live, even though weakened pathogen, they might not be suitable for everyone. Specifically, people with weakened immune systems, say due to illness or certain medical treatments, for them, even an attenuated pathogen could potentially cause problems. So scientists needed other options.
Ah, okay. So the next logical step was trying to get immunity without using a live bug at all. What did that look like?
Precisely. That led to inactivated vaccines. These are made from bacteria or viruses that have been killed, usually using heat or chemicals.
Killed so they can't replicate.
Correct. They can't cause disease at all. But crucially, they still have their antigens intact, those identifying flags we talked about. Those antigens are enough to stimulate an immune response.
Safer for more people then.
Generally, yes, because there's zero risk of the pathogen causing even a mild infection. They're safer for a broader population. The trade-off, though, is that the immune response might not be as strong or long-lasting as with live vaccines. So they typically require multiple doses initially, and often booster shots later on, to build up and maintain that protective immunity.
Examples.
Classic examples are the inactivated polio vaccine and many types of influenza vaccines.
Okay, so we have live weakened and killed whole. Then you mentioned vaccines using just pieces, like a more targeted approach.
You got it. Those are subunit or component vaccines. Instead of the whole organism, live or dead, these vaccines only include specific purified parts of the pathogen.
Like what parts?
It could be proteins from the surface, or maybe the sugary coating, the polysaccharides, on some bacteria. Because they only contain these fragments, they are inherently very safe. They absolutely cannot cause infection.
So good for vulnerable groups.
Ideal, yes. Great for young children, older adults, people with compromised immune systems who might not handle live vaccines well. And within this category, you have different subtypes. There are polysaccharide vaccines, conjugate vaccines, where they cleverly link a sugar molecule to a protein to get a better immune response, especially in infants, and protein-based vaccines.
Which vaccines fall under this?
Think hepatitis B, Haemophilus influenza type B or Hib, the pneumococcal vaccine, the newer shingles vaccines, and a special type of subunit vaccine is the toxoid vaccine.
Toxoid, like toxin.
Exactly. Some bacteria cause disease by releasing harmful toxins. Toxoid vaccines are made from inactivated versions of these toxins. So your immune system learns to fight the toxin itself, not necessarily the bacteria directly. Tetanus and diphtheria vaccines are the prime examples here.
Okay, that covers a lot of ground. But now let's get to the really new stuff, the genetic vaccines. This feels like where things got, well, revolutionary, especially with COVID-19. What makes them so different?
This is truly one of the most significant leaps in vaccinology in, well, decades. Genetic vaccines. Yep. This includes DNA vaccines, though those are less common in humans right now. And the big one, messenger RNA or mRNA vaccine.
mRNA, everyone knows that term now.
Right. Instead of injecting the antigen itself, these vaccines deliver the genetic instructions, the mRNA sequence, for a specific pathogen antigen, like the spike protein of the coronavirus.
So our own cells make the antigen.
Exactly. Your cells read the mRNA instructions and temporarily produce the antigen protein themselves. They become tiny, temporary antigen factories. These self-made antigens then trigger the immune response, teaching your body how to recognize and fight the real pathogen if it ever shows up.
And why was this so fast for COVID?
A key advantage is speed and scalability. They rely on enzymatic reactions to make the mRNA, not complex, slow processes like growing viruses in cells or eggs. This allows for greater purity, potentially higher yields, and a much, much shorter development and manufacturing timeframe compared to traditional methods.
Wow.
This shift really reflects a deeper understanding of immunology, of molecular biology. It allows for incredibly targeted antigen presentation. And it fundamentally changed our ability to respond rapidly to a pandemic, as we all saw. It turned years into months.
Are there other related types?
Yes, a related platform is recombinant vector vaccines. These use a different harmless virus, the vector, to act like a delivery truck.
The delivery truck for genes.
Essentially, yes. The vector virus is engineered to carry the genetic material encoding the target pathogen's antigen into your cells. Once inside, your cells use those instructions to produce the antigen, kicking off the immune response. Some of the other COVID-19 vaccines, like the Johnson & Johnson or AstraZeneca ones, use this vector technology, also very agile in a crisis.
Okay, so that's the individual protection. But you mentioned something earlier about a community benefit, herd immunity.
Absolutely. And this concept of herd immunity, or community immunity, is critical for public health on a large scale. It happens when a large enough portion of a population becomes immune to a specific pathogen.
Through vaccination or infection.
Either, yes. When enough people are immune, it creates this kind of collective shield. It significantly reduces the pathogen's ability to circulate, to find susceptible people to infect.
So it protects people who aren't immune.
Exactly. It provides crucial indirect protection for those who aren't immune. Maybe infants too young to be vaccinated yet, people with severely weakened immune systems who can't mount a good response to vaccines, or those few who have genuine medical reasons not to be vaccinated. It's a powerful example of how individual choices getting vaccinated directly contribute to the health and safety of the entire community. It really is a collective effort.
Let's step back in time now. Our vaccine journey really kicks off in the late 18th century. And it starts with, well, a pretty keen observation and maybe a bit of a leap of faith. It's almost legendary, the story of Jenner.
It really is. And Edward Jenner's work, it's the absolute bedrock of vaccinology,
Oh.
of modern public health, really.
Yeah.
Before him, smallpox was just devastating, a constant, terrifying presence.
Causing huge numbers of deaths, terrible scarring.
Immense morbidity and mortality worldwide. What's so fascinating is that Jenner, just a country doctor, paid attention to local folklore. He noticed that milkmaids who contracted cowpox, this much milder disease from cows, seemed to be protected from smallpox.
This wasn't totally unknown, right? But he tested it.
He decided to rigorously test it, yes. In 1796, he did his famous experiment. He took material from a cowpox sore on a milkmaid's hand and inoculated an 8-year-old boy, James Phipps.
Brave kid.
He was. And then later, Jenner deliberately exposed Phipps to smallpox material, and the boy didn't get sick.
Wow, that must have been incredible to witness.
It was groundbreaking empirical evidence, proof that cowpox infection could protect against smallpox. Jenner meticulously documented this in his publication, An Inquiry into the Causes and Effects of the Variolae Vaccinae. This laid the scientific foundation for vaccination.
Then led eventually to...
Ultimately, it culminated in the global eradication of smallpox in 1980, a truly monumental achievement in all of human history, a testament to the power of this idea. And the word vaccine itself, it comes from vacca, the Latin word for cow, honoring Jenner's discovery. Just imagine, wiping a disease off the face of the earth.
Incredible. Then almost a century later, another giant steps in, Louis Pasteur. He brought real laboratory science into it, right? Often called the progenitor of modern immunology. How did he build on what Jenner started?
That's a great question, because Pasteur really shifted vaccination from this brilliant observation into a systematic scientific discipline. First, he championed the germ theory of disease, proving that specific microbes cause specific illnesses. That was huge.
Right, not bad air or imbalances, actual germs.
Exactly. And crucially, Pasteur proposed that vaccination wasn't just limited to naturally related diseases like cowpox and smallpox. He believed it could be applied to any microbial disease. He developed methods to attenuate virulence.
Attenuate, meaning weaken.
Yes, weaken the microbes in the lab so they wouldn't cause severe disease but would still trigger immunity. He did this famously for fowl cholera around 1878, and then anthrax in 1881, sometimes just by exposing the bacterial cultures to air or tweaking how they were grown.
So he was engineering vaccines, essentially.
He was. And his most celebrated achievement, the one that really captured the public imagination, was the rabies vaccine in 1885.
Rabies, a terrifying disease. How did he do that?
He took the virus from infected animals and passed it through a series of rabbits. Then he dried the infected spinal cord tissue from the rabbits for varying lengths of time to gradually reduce the virus's virulence.
And then the famous case.
The pivotal moment, July 6, 1885. He administered this experimental vaccine to a 9-year-old boy, Joseph Meister, who had been terribly bitten by a rabid dog. And Meister survived. It was a landmark moment, also demonstrating therapeutic vaccination, giving a vaccine after exposure to prevent the disease from developing.
Amazing. Did he fully understand how it worked immunologically?
Not perfectly, no. His understanding of the immune mechanisms wasn't quite right by today's standards, but his practical methods for attenuation, his rigorous lab approach, and his vision for applying vaccination broadly that was absolutely transformative, he showed the world how to make vaccines deliberately.
So we have Jenner, the sharp observer validating folk wisdom, and Pasteur, the systematic scientist creating vaccines in the lab. Looking back, what does this sequence tell us about how science actually moves forward? Is it always neat and tidy?
That's a really insightful point.
Yeah.
If we connect this to the bigger picture of scientific progress, it clearly shows it's not always a straight line. It doesn't always follow one single method. Jenner's discovery was pure empirical observation. He proved a practical link worked without fully understanding the why, the complex immunology underneath. Pasteur, on the other hand, deliberately manipulated microbes using controlled lab methods. He articulated a general principle attenuation that could be applied to many diseases. He focused on the how.
So breakthroughs can happen before we fully get the theory.
Absolutely. Groundbreaking public health interventions can, and often do, come before we have the complete mechanistic picture. The immediate impact on saving lives, on reducing disease burden, can be enormous, even if the underlying science is still being figured out. These early practical successes then fuel further research, leading to deeper theoretical understanding and even broader applications later on. It's this dynamic interplay between seeing something works and figuring out how to make it work reliably and for other problems.
Then came the 20th century, and things really took off. An explosion of vaccine development, new science, better manufacturing. What were some of the key milestones that really shaped the public health landscape we know today?
Oh, the 20th century was truly transformative. It's when vaccination went from targeting a few diseases to tackling a whole range of major infectious threats. The scale and impact just grew exponentially.
Where did it start?
Well, early on, in 1921, we got the first vaccine for tuberculosis, the BCG vaccine, still used in many parts of the world today. Then, just a couple of years later, 1923, 1924, the first diphtheria and tetanus vaccines arrived. These were toxoids, remember, proving you could fight the toxin, not just the bug.
Right.
1932 saw the first yellow fever vaccine, absolutely crucial for regions plagued by that disease, followed by the first influenza vaccine in 1937.
Then came combinations, making it easier for kids.
Yes, a really important step in 1948 was the introduction of the first combination vaccines. The big one was DTP, diphtheria, tetanus, and pertussis, or whooping cough. Combining shots meant fewer injections for kids, better compliance, and getting protection against multiple diseases faster. That was huge for childhood immunization programs.
And the 50s, polio?
The 1950s were dominated by the fight against polio, a terrifying disease causing paralysis. First, Jonas Salk developed the inactivated poliovirus vaccine, the IPV shot, rolled out between 1952 and 1955. Then Albert Sabin developed the oral, live-attenuated polio vaccine, OPV, the drops, between 1956 and 1962. Together, these vaccines dramatically reduced polio cases worldwide, bringing us to the brink of eradication today.
What came next in the 60s and 70s?
1963 saw the first licensed measles vaccine, targeting a major childhood killer. Then in 1971, the legendary Maurice Hilleman, honestly, a giant in vaccine development, responsible for dozens of vaccines combined measles, mumps, and rubella into this single MMR vaccine. Again, streamlining childhood shots, boosting coverage rates massively.
Any other major firsts later in the century?
Absolutely. 1981 was a landmark year with the approval of the first hepatitis B vaccine. This was groundbreaking because Hep B is a major cause of liver cancer. So this became the first vaccine to prevent a form of cancer, a huge conceptual leap.
Wow, a cancer-preventing vaccine.
Exactly. And finally, in 1984, the first vaccine for chickenpox, varicella, was developed in Japan, turning another common, sometimes serious childhood illness into a preventable one. It really was a century of relentless progress, driven by scientific discovery and a growing commitment to public health.
It's truly an incredible timeline. It takes us from Jenner's single observation to this whole arsenal of protection, fundamentally changing childhood, lifespan, how we live. It's a clear trajectory of scientific pursuit saving millions of lives. Okay, let's pivot now to some specific diseases and the vaccines we use today. Let's start with influenza, the flu. That seasonal headache that seems to require constant vigilance, it really feels like a moving target.
It absolutely is a moving target, and that's influenza's defining challenge. We first isolated the virus back in the 1930s, confirming it was a virus.
Yeah.
And a key early breakthrough came in 1936 when Burnett discovered you could grow it in fertilized hen's eggs.
Eggs, we still use that method a lot today, right?
We do. It's a testament to its reliability, but it also has some limitations we can maybe touch on. The very first inactivated flu vaccine was developed in the 1940s, actually by Thomas Francis Jr. and Jonas Salk.
Salk of polio fame.
The very same. Initially for U.S. troops during World War II, targeting influenza A. By 1942, they had a bivalent vaccine covering A and B strains. Annual flu shot recommendations, especially for older adults and high-risk groups, started rolling out in the 1960s. But it took time to refine the process and improve effectiveness.
So what makes it such a moving target? Why do we need a new shot every year?
The core problem is the virus's constant evolution, specifically something called antigenic drift.
Antigenic drift sounds shifty.
It is. The virus's surface proteins, the antigens that our immune system recognizes, subtly change over time. It's like the virus keeps tweaking its disguise just enough to evade the immunity we built up from previous infections or vaccinations.
So last year's immunity might not work this year.
Exactly. This forces health authorities to constantly monitor circulating strains globally and reformulate the seasonal vaccine twice a year. One formulation for the Northern Hemisphere's flu season, another for the Southern Hemisphere.
Twice a year. That sounds intense.
It is. And this whole production timeline is a major challenge. Because it takes months to produce the hundreds of millions of doses needed, the decision about which strains to include in the vaccine has to be made 7 to 8 months before the flu season actually starts.
So we're essentially predicting the future, trying to guess which strains will be dominant almost a year ahead.
That's basically it. It's an educated guess based on global surveillance, but sometimes the virus throws a curveball and the match isn't perfect.
So what's the future look like for flu shots? Are we getting better at hitting this moving target?
There's a huge amount of research focused on exactly that, improving effectiveness, making protection last longer. Novel platforms are key here. mRNA vaccines are showing a lot of promise.
mRNA for flu, like the COVID vaccines.
Precisely. Companies like Moderna, with their mRNA 1010 candidate, and Pfizer, with their quadrivalent modRNA vaccine, QIRV, are already in late-stage Phase 3 clinical trials.
What's the advantage of mRNA here?
The hope is increased antigenic fidelity, meaning the vaccine antigens might be a closer match to the circulating strains. It could also potentially shorten that manufacturing timeline, maybe allowing strain selection closer to the actual flu season and avoiding mutations that can sometimes happen when growing viruses in eggs. Imagine reacting to strains as they emerge, not months in advance.
That would be a game changer. What about the Holy Grail, a universal flu vaccine?
The universal flu vaccine, that's the ultimate goal. A vaccine that would protect against a wide range of influenza viruses, maybe even different subtypes, and provide much longer-lasting immunity, perhaps for several years or even longer.
Is that close?
Researchers are actively working on it, targeting more conserved parts of the virus that don't change as much. But it's complex. Most experts think a truly universal flu vaccine is probably still at least 10 years away, maybe more. It requires a lot of rigorous research and testing to ensure it's safe and broadly effective.
So, with the current shots, given the prediction challenge and antigenic drift, what's the real-world impact? Are they still worth getting?
Absolutely. Influenza vaccination is, without doubt, the most effective tool we have to control the flu, especially for protecting vulnerable populations, even with its current limitations.
How effective are they, typically?
When the vaccine strains are a good match for the circulating viruses, effectiveness is estimated to be around 40% to 60% in preventing illness.
40 to 60%. That doesn't sound super high.
It might not sound amazing, but you have to consider the scale. Globally, seasonal flu causes roughly 5 million severe cases, and tragically, around 500,000 deaths every single year.
Wow, okay.
And high-risk groups, especially people 65 and older, bear the brunt of that. They account for 50–70% of flu-related hospitalizations and 70–85% of flu-related deaths in that age group. So preventing 40–60% of infections in that context translates to saving hundreds of thousands of lives and preventing millions of hospitalizations and severe illnesses. It makes a huge difference.
But uptake is still low sometimes.
That's the other challenge. Despite clear recommendations, uptake rates remain disappointingly low in many parts of the world. You mentioned Jordan. Only 11.4% of older adults got the shot in 2022-23. That leaves a lot of people unnecessarily vulnerable. These next-generation vaccines, if they pan out, could potentially prevent billions more infections, but realizing that potential means also tackling issues of cost, access, and public trust, especially bridging the gap between high-income and lower-income countries.
Okay, let's shift to RSV, Respiratory Syncytial Virus. This one is a big deal, especially for babies and older adults, and its vaccine story. Well, it had a really rough start, didn't it?
That's putting it mildly. The RSV vaccine journey is a stark reminder of how complex vaccine development can be and how crucial it is to learn from failures. Early attempts back in the 1960s were, frankly, catastrophic.
What happened?
In 1966, there was a trial using a formalin-inactivated RSV vaccine, FIRSV. They gave it to infants. Tragically, when these vaccinated infants were later naturally infected with RSV, they developed a more severe form of the disease.
More severe? How is that possible?
It's a phenomenon called vaccine-associated enhanced respiratory disease, or VAER. It led to increased hospitalizations and, devastatingly, 2 deaths among the vaccinated infants in that trial. It was a terrible setback, and it understandably halted RSV vaccine development for decades. Scientists were terrified of repeating that mistake and needed to figure out why it happened.
So what was the critical mistake? What did they eventually learn?
It took a long, long time and advances in molecular biology and structural biology to figure it out. The key discovery revolved around the structure of a crucial RSV surface protein, the F protein. This protein changes shape dramatically during the process of infecting a cell. It goes from a pre-fusion state to a post-fusion state.
Pre-fusion and post-fusion. Okay.
The failed 1960s vaccine, the FIRSV, it turned out, mostly contained the post-fusion form of the F protein. And that form, unfortunately, doesn't elicit the most effective neutralizing antibodies. In fact, it might have triggered a harmful immune response.
Ah, so the trick was targeting the other form.
Exactly. The major breakthrough came when scientists figured out how to stabilize the F protein in its pre-fusion form, pre-F. This pre-F shape presents the most important sites, the critical neutralizing epitopes that powerful antibodies can bind to. Vaccines based on this stabilized pre-F protein elicit a much stronger, much more protective immune response. That structural insight was the absolute game changer.
And that breakthrough led to...
It unleashed a wave of development. After decades of frustration, the last few years have seen incredible progress, culminating in the truly exciting news.
Yeah.
The first RSV vaccine approvals finally happened in 2023.
Finally. What's available now?
In the U.S., there are currently 3 approved vaccines. There's Arexvy from GSK, initially for adults 60 and older, and recently expanded to include those aged 50–59 who have certain underlying medical conditions that increase their risk.
Okay.
Then there's Abrysvo from Pfizer, also approved for adults 60 and older. But remarkably, Abrysvo is also approved for pregnant individuals, given between 32 and 36 weeks of gestation.
For pregnant women. Why?
To protect their babies.
Yeah.
The antibodies the mother generates after vaccination cross the placenta, providing protection to the infant from birth through the first few months of life when they are most vulnerable to severe RSV. It's a fantastic strategy.
That's brilliant. And the third one?
The third is Mrezvia from Moderna. This one is an mRNA vaccine, similar technology to their COVID vaccine, and it also targets that crucial pre-fusion F protein. And beyond vaccines, we also have powerful tools like monoclonal antibodies, ABs.
Like nirsevimab.
Exactly. Nirsevimab is a long-acting mAb specifically for infants and young children. It provides passive immunity, those ready-made antibodies, and has shown amazing efficacy, reducing RSV-related hospitalizations by over 90% in clinical trials. And it usually just requires a single shot for the season, which is a huge advantage over older mAbs. So we now have this multi-pronged approach: vaccines for older adults, maternal vaccination, and mAbs for infants.
That's incredible progress after such a dark history. Are there any remaining concerns or challenges now that these are rolling out?
Yes, as with any new vaccine, ongoing monitoring and research are crucial. We need to balance safety, how well they work, and how long protection lasts, especially across different populations. Post-marketing surveillance is watching carefully for any potential rare adverse events.
Like what?
Well, one thing that's being closely monitored is a small but observed increase in diagnoses of Guillain-Barré syndrome, GBS, following vaccination with either Abrysvo or RSV in older adults.
GBS, that's a neurological condition, right?
Yes, a rare neurological disorder where the immune system attacks the nerves. The absolute risk appears very low, maybe around 1.5 cases per million doses for RSV, for example. But it's statistically significant enough that the FDA has required warnings in the prescribing information. It's a top priority for investigation to understand the precise relationship, if any.
Okay, so ongoing safety monitoring is key. Any other challenges?
We also still need more data on how well these vaccines work in specific, highly vulnerable groups, like people who are severely immunocompromised or very frail elderly individuals, as they weren't always well represented in the initial large clinical trials.
Makes sense. But overall, a huge step forward.
Unquestionably, RSV is a massive health burden. In the U.S. alone, it causes up to 2.1 million outpatient visits for kids under 5 each year, and between 60,000 and 160,000 hospitalizations for adults over 65 annually. These new vaccines and mAbs represent a monumental leap forward in protecting those most at risk. It's really a new era for RSV prevention.
Okay, let's talk COVID-19. That pandemic changed everything for a while, and the vaccine development story was just unprecedented. It catapulted mRNA technology from relative obscurity into the global spotlight. What enabled that incredible speed?
It really felt like science fiction unfolding in real time, didn't it? If we connect this to the bigger picture, several things converged. The urgency was obviously immense. But critically, we weren't starting from absolute zero. We had existing knowledge from studying previous dangerous coronaviruses, the ones that caused SARS and MERS.
Right, scientists had studied those cousins of COVID-19.
Exactly. That gave researchers a head start understanding the virus's structure, particularly the spike protein, which became the main target for most vaccines. Before COVID, remember, no vaccine for any infectious disease had ever been produced in less than several years. And we had no vaccine at all for preventing any human coronavirus infection.
So what was the real magic ingredient for that speed?
The true game changer was the decades of foundational research on mRNA technology. This was largely pioneered by scientists like Katalin Karikó and Drew Weissman, starting way back in the late 1990s.
So this wasn't an overnight invention.
Not at all. They worked for years, often with limited funding and recognition, figuring out how to modify mRNA so it could be used safely and effectively as a vaccine or therapy, crucially overcoming problems like triggering harmful inflammatory responses. Their persistence and breakthroughs made the Pfizer-BioNTech and Moderna COVID-19 vaccines possible. That prior, often unsung basic research was absolutely essential for the rapid response.
And there's always
Unprecedented speed. The first COVID-19 vaccines went from genetic sequence identification to being available to the public under emergency authorizations in less than 11 months. Less than a year.
just incredible.
By August 2024, something like 13.72 billion doses had been administered worldwide. The scale of development, manufacturing, and distribution was just mind-boggling. A true scientific and logistical marathon run at sprint speed.
Is the work done now, or is research still ongoing for COVID vaccines?
Oh, it's definitely not done. Research continues intensely. One goal is developing second-generation vaccines. Things like making them more easily adaptable to new variants as they pop up, making them thermostable.
Meaning they don't need ultra-cold storage.
Exactly. Less reliance on complex cold chains would be huge for global distribution, especially in lower resource settings. There's even research into vaccines that might integrate into the human genome for very long-lasting immunity, although that's more futuristic.
What about dealing with all the variants?
That's a major focus. Developing universal coronavirus vaccines. Vaccines that target parts of the virus that are common across many different coronaviruses, including future ones, and don't mutate as rapidly as the spike protein does.
A pan-coronavirus vaccine?
Sort of, yes. Such a vaccine could be a true game changer, even if it only provided partial protection. Having something ready to go immediately at the start of a new coronavirus pandemic could act as a vital stopgap, slowing spread and severity while more specific vaccines are developed. It could save potentially billions of dollars and, more importantly, millions of lives.
So, on one side, this amazing scientific achievement. But the pandemic also threw some major challenges into sharp relief, didn't it? Both scientific and, maybe even more so, societal.
Absolutely. It was a stark reminder that science alone isn't enough. Scientifically, the virus's rapid evolution into variants, alpha, beta, gamma, delta, omicron, and all its sublineages was a constant headache.
Right, making the vaccines less effective over time.
Exactly. It
Yeah.
reduced effectiveness against infection, though thankfully protection against severe disease held up better. It also complicated research. Finding truly unvaccinated comparison groups for studies became harder as more people got vaccinated or infected. And then there's waning immunity. Protection fades over time, necessitating booster doses and updated vaccine formulations, like the JN1 targeted shots being planned for the 2025-26 season. It's this ongoing arms race between the virus and our defenses.
And the societal challenges, those felt huge.
They were, and arguably even more difficult to tackle. We saw an unprecedented wave of vaccine hesitancy, often fueled by a deluge of misinformation and disinformation spreading like wildfire online. This directly impacted vaccine uptake, even in places with plentiful supply.
And the issue of fairness, global access.
That was perhaps the most painful lesson. The pandemic exposed deep systemic inequities in global vaccine access. High-income countries secured the vast majority of early doses, leaving low- and middle-income countries waiting for months, sometimes years.
How did that happen?
Complex factors were involved, but global policies around intellectual property rights, patents, and trade agreements played a significant role. They affected where vaccines could be manufactured and how quickly they could be distributed equitably. This delay in getting vaccines to vulnerable populations worldwide undoubtedly prolonged the pandemic, cost lives, and worsened existing global health inequalities. It undermined the whole idea of universal health coverage.
So even with effective vaccines, getting them to everyone was a massive hurdle.
A massive hurdle. Still, it's crucial to remember that the COVID-19 vaccines did provide meaningful protection against severe disease, hospitalization, and death, especially for high-risk groups like older adults and infants under 6 months who consistently had the highest hospitalization rates. The pandemic was a crucible. It showed us the breathtaking power of modern vaccinology, but also laid bare the urgent need for global collaboration, equity, and combating misinformation to face future threats effectively.
Okay, let's shift gears to something that felt like a standard part of childhood for so many generations: chickenpox. That itchy, spotty illness. Vaccination has really changed the game there, hasn't it? It's almost rare to see it now in some places.
It really is a remarkable transformation, and it raises that interesting point about diseases once considered mild childhood rites of passage, but which actually carried real, albeit often underestimated risks.
People forget it could be serious sometimes.
Exactly. And historically, varicella, chickenpox, was so common, it wasn't even reliably distinguished from smallpox until the late 19th century. The virus itself was finally isolated in cell culture in 1954 by Thomas Weller. That paved the way for developing the vaccine.
And who developed the vaccine?
The live, attenuated vaccine, based on what's called the Oka strain, was developed by Dr. Michiaki Takahashi and his team in Japan in the early 1970s. They isolated the virus from a healthy child who had a typical case of chickenpox.
So they weakened that specific virus strain.
Yes, through careful passage in different cell cultures. The vaccine first became available commercially in Japan and Korea in 1984. Then it was licensed in the U.S. in 1995. And later, in 2005, we got the combination MMRV vaccine, adding varicella to measles, mumps, and rubella, making the schedule even simpler for kids.
How effective is it? Does it really stop chickenpox?
It's highly effective. 2 doses provide about 90% to 98% protection against getting chickenpox at all. And is even better, 94% to 98% effective at preventing moderate or severe disease.
So breakthrough cases are usually mild.
Generally, yes. Very mild. And this isn't just about avoiding the itchiness and missed school days. It's about preventing potentially serious complications.
Like what?
Things like bacterial skin infections from scratching, pneumonia, inflammation of the brain, encephalitis, or bloodstream infections. Rare but serious. Since the U.S. vaccination program started in 1995, the impact has been stunning.
How big a drop?
Chickenpox cases have decreased by an average of 97% across all age groups. Hospitalizations due to varicella are down 93%, and deaths are down 94%. It's a massive public health success story, driven by direct protection and also strong herd immunity effects.
That's incredible. Are there any lingering questions or maybe unexpected consequences now that chickenpox is so much rarer? I feel like I've heard discussions about shingles.
That's a valid point people raise. While chickenpox is usually mild, preventing those rare serious complications is a key benefit of the vaccine. Now, about shingles, or herpes zoster, that's caused by the same virus as chickenpox, the varicella zoster virus. After you have chickenpox, the virus lies dormant in your nerve cells. Years later, often in older adults or when the immune system is weakened, It can reactivate and cause shingles, which can be very painful.
So the concern was if there's less chickenpox circulating, maybe older people's immunity to the virus wouldn't get boosted naturally by occasional exposure, leading to more singles.
That was the hypothesis, yes, a plausible concern. However, years of surveillance data, mostly from high and middle-income countries with widespread varicella vaccination programs, have generally not shown a definitive, consistent link.
So the vaccine program didn't cause a big shingles epidemic.
It appears not. While shingles rates have been increasing for various reasons over decades, the evidence does not definitively and consistently associate universal varicella vaccination with an increase in herpes zoster incidence in the elderly. It's something scientists continue to monitor, but that specific fear seems largely unfounded based on current data.
What about how long the vaccine protection lasts?
That's another area of ongoing research. We are seeing that immunity can wane over time in some individuals. Studies have shown some children losing protective antibody levels maybe 5 to 8 years after their second dose.
So boosters might be needed eventually.
It's possible, especially as natural boosting from circulating wild-type virus becomes much rarer due to high vaccination rates. The optimal long-term strategy is still being evaluated. And like with any vaccine program, maintaining public trust through clear communication is vital. Addressing potential out-of-pocket costs for patients is also important to ensure recommendations are followed and manufacturing remains viable.
Okay, last deep dive. Measles. An ancient disease, incredibly contagious, airborne. Its story seems to capture both the absolute triumph of vaccination and, more recently, the worrying challenges we face. It feels like a real cautionary tale.
It is an incredibly stark one. What's almost hard to fathom now is the sheer devastating impact measles had before vaccines. It was described way back in the 9th century. It was endemic everywhere, causing huge epidemics every few years. Before widespread vaccination, measles killed an estimated 2.6 million people annually, mostly young children.
2.6 million deaths a year, just from measles.
Globally, yes, it was a relentless killer. The modern journey to control it began in 1954, when Drs. John F. Enders, often called the father of modern vaccines for his work on growing viruses in culture, and Thomas C. Peebles isolated the measles virus, the Edmonton strain.
And Enders developed the vaccine.
Yes, based on that strain, leading to the first licensed measles vaccine in 1963. Later, the amazing Maurice Hellman improved the vaccine strain, making it safer and more effective, and then combined it with mumps and rubella components into the single MMR shot in 1971. That combination was another masterstroke for public health delivery.
And the impact of the measles vaccine globally.
It's been arguably one of the most successful public health interventions in history, just staggering numbers. Between the year 2000 and 2023 alone, measles vaccination is estimated to have prevented around 60 million deaths.
60 million in just over 2 decades.
Yes. And over the last 50 years, the total number of deaths averted worldwide is likely over 90 million. It's arguably the single most life-saving childhood vaccine currently in use. The U.S., for example, achieved elimination of endemic measles transmission back in 2000, meaning it was no longer constantly circulating within the country. A huge victory.
So if it's that effective, that successful, why are we hearing about measles outbreaks again? What's driving this resurgence? It seems unbelievable.
It's the painful paradox, isn't it? Despite having this incredibly safe and effective tool, we're seeing declines in vaccination rates in various parts of the world. And a major driver of this is misinformation and disinformation about vaccine safety and necessity, spreading rapidly, often online.
Leading to outbreaks.
Directly. For instance, just from January 1st to April 17th, 2025, the U.S. reported 800 measles cases. That's the second highest annual count in 25 years. A truly alarming setback. And get this, 82% of those cases were linked to an ongoing outbreak centered in communities with known low vaccination coverage in New Mexico, Oklahoma, and Texas.
So unvaccinated pockets are driving it.
Absolutely. The COVID-19 pandemic also didn't help. It disrupted routine immunization services and surveillance systems globally, creating more vulnerability to imported cases, sparking outbreaks.
How contagious is measles, really?
It's one of the most contagious viruses known to humanity. It hangs in the air for hours after an infected person leaves a room. Because it's so incredibly infectious, you need extremely high vaccination coverage to stop it. At least 95% of a community needs to have 2 doses of vaccine to achieve herd immunity and prevent outbreaks.
95%, that's a very high bar.
It is. And while overall childhood vaccination rates might be high nationally in places like the U.S., if coverage dips significantly in smaller communities or specific groups, it creates these dangerous pockets of susceptibility. The virus finds those gaps. The resurgence is a direct tragic consequence of vaccine hesitancy and falling coverage. It highlights the very real dangers of misinformation and the absolute necessity of maintaining high immunization rates. It's a constant battle we can't afford to lose.
Is there anything new on the horizon for treating measles if someone does get it?
There is some hopeful research. A new pipeline discovery program is underway to develop a monoclonal antibody AM treatment.
Antibodies, again, like for RSV.
Exactly. The goal is to have a highly neutralizing mAb therapy that could be given to people with active measles infection, or potentially as post-exposure prophylaxis treatment after being exposed but before getting sick.
Who would that help most?
It could be crucial for protecting the most vulnerable. Infants too young for the MMR vaccine, people who are immunocompromised and can't be vaccinated or don't respond well, maybe even older individuals whose immunity has waned. It wouldn't replace vaccination, but it could be a vital tool for those who can't rely on the vaccine or get caught in an outbreak.
But prevention is still key.
Absolutely. Despite having this incredibly safe and effective vaccine for decades, an estimated 107,500 people still died from measles globally in 2023. Mostly unvaccinated or undervaccinated children under 5, that number should be 0. It's a stark reminder of the ongoing global challenge, ensuring equitable access, building trust, and combating misinformation to protect children from a completely preventable disease.
Wow. What an incredible journey we've just traced, from Jenner's really astute observation about milkmaids centuries ago,
Right. Simple but profound.
all the way to mRNA vaccines being designed, tested, and deployed in just a matter of months during a global crisis. The story of vaccines is just one of relentless ingenuity, isn't it? Scientific perseverance, and yeah, sometimes learning things the hard way, like with RSV.
It really is. And what's fascinating is how those foundational principles laid down by Jenner and Pasteur, even though their understanding of the underlying immunology was, incomplete by today's standards, consistently proves the core concept. Controlled exposure can induce immunity and dramatically reduce disease burden.
Their practical successes paved the way.
Absolutely. Whether it's Jenner's empirical link or Pasteur's deliberate attenuation in the lab, they showed it could be done. And that success fueled everything that came after.
And the evolution since then.
It's been profound. Moving from using whole pathogens live or killed to these incredibly precise genetic technologies like mRNA. It represents this huge leap in our capabilities. We can now design vaccines with really tailored safety profiles, fine-tune how well they trigger an immune response, that immunogenicity, and crucially, manufacture them with incredible speed and scale. That adaptability is just essential now in an era where viruses like influenza and SARS-CoV-2 evolve so rapidly.
But it's not a finished story, is it? Despite these amazing successes, what are the hurdles still standing in our way? What's stopping this from being a complete revolution?
That's the critical question because, significant challenges definitely persist. On the scientific front, we're still grappling with things like viral antigenic drift, that moving target problem with flu.
Yeah.
We're dealing with waning immunity from many vaccines, which necessitates booster shots and ongoing research into durability. And the quest continues for those elusive universal vaccines, ones that could protect broadly against highly changeable pathogens like influenza and coronaviruses. Those remain very active, very well-funded areas of intense research. We're constantly pushing those scientific boundaries.
And it's not just the science, right? As we saw with COVID and now with measles, it's also about people, about policies, access, trust.
Exactly. You can have the best vaccine in the world, but its impact depends entirely on getting it to the people who need it and ensuring they trust it. If we connect this to the bigger picture, the full public health power of vaccination is increasingly shaped by these complex societal factors.
Like vaccine hesitancy.
Yes, vaccine hesitancy, often amplified by the rapid spread of misinformation, is a major obstacle. We see its direct tragic consequences in the resurgence of diseases like measles in communities where vaccination rates have fallen.
And the access issue.
And the profound, persistent inequities in global vaccine access. The COVID-19 pandemic threw that into painfully sharp relief. We saw how global policies, things like intellectual property rules and trade agreements, directly impacted manufacturing and distribution, leading to vaccine nationalism and delaying access for billions in lower-income countries. This inequitable distribution didn't just worsen health inequalities, it likely prolonged the pandemic for everyone. It showed that our scientific brilliance can still be hobbled by systemic failures and a lack of global solidarity.
So it's this constant, almost dynamic interplay. We make scientific leaps, but then we face these human challenges, these systemic barriers to actually realizing the full benefits.
Precisely. The history of vaccines is this incredible testament to human ingenuity in fighting infectious diseases. It's a story of progress against daunting odds. But while scientific advances keep pushing the frontiers of what's possible, achieving the full life-saving potential of these tools hinges just as much on addressing the non-scientific challenges. We need to tackle the biological complexities of pathogens and the socioeconomic barriers, the communication failures, the trust deficits, and the inequities that impact vaccine uptake and access all around the world. This constant dance between science and society will absolutely continue to shape the future of global health security for all of us.
This deep dive really drives it home. Vaccines aren't just a triumph of lab coats and microscopes. They're a testament to humanity's ongoing struggle, our fight for a healthier future for everyone. It's an amazing story. Ingenuity, perseverance, setbacks, breakthroughs.
It really is. That journey from Jenner just noticing something about cowpox to the incredibly rapid design and deployment of mRNA vaccines, it shows this continuous arc of innovation and the impact on reducing disease, on extending lives. It's just profound, almost immeasurable.
So we've covered the science, the incredible history, the current tools, and the challenges that remain. What does this all mean for you, the listener, as you think about this constant interplay, these amazing scientific leaps forward, bumping up against societal hurdles like access and trust? Maybe ask yourself this. How does our individual understanding of this complex, sometimes messy, but ultimately hopeful history empower us, each of us, to contribute to the collective health and security of our own communities, especially as we face inevitable future infectious disease threats?